All right, good morning, everyone. We are placing a Chemoport for this gentleman with pancreatic cancer. My approach is the internal jugular vein for almost all central lines, especially for a port. So for that, I'm going to use an ultrasound, which we're seeing here. I'll show you how we do ultrasound guidance for the central line placement. Other surgeons like to do subclavian, which is higher risk for iatrogenic injury like pneumothorax, hemothorax. So I prefer to do the internal jugular approach. It's very, very simple and very, very safe, which you'll see. But first, I'm going to orient you to the patient. So this is the right neck. His face is under there. His feet are down there. This is our ultrasound probe. So I'm going to identify the jugular vein, which we see as this collapsed structure there with the artery below it. I'm going to have the anesthesiologist put our patient into Trendelenburg position. So this position makes the patient head down. So it's going to engorge the vein and make it more plump, as you see there, as a little bit more to right. Very good. And then table up. So as the patient is head down, the vein is underneath the level of the heart, so it engorges the low pressure venous system, which makes it more plump, which is that little line there, which makes a larger target for me to access with my needle. So we're going to use the cell injury technique to access the internal jugular vein. So the way we do this is we visualize the jugular vein. So there's two circles there. The top one, right in the middle, that big fat blob is the jugular vein on the right side. Underneath it is an artery. And sometimes you can't really tell based on size, so a good way to do it is to press down on the skin, which collapses the weak pressured vein, but the artery does not move at all because it's a muscular thing. So that's a quick way to identify the vein versus the artery, and you want to go into the vein, obviously. So the vein is the one on top. So with my ultrasound, I'm going to use the needle to punch through the skin. And then I'm going to watch the needle bounce the skin. You can see a little bit of movement there. So you can see the needle go right into the vein right there. So there's a tip of the needle within the vein. So you want to kind of punch through it, so make sure you go through the wall. So a little challenge because I don't want to go too far and get into the artery, so we're going to take our time. Reset. So I felt a little pop. I saw the vein or the needle in the middle of the vein. I'm withdrawing some blood. It's not spurting out, so we're not in the artery, we're in the vein. So this is a micro wire. What? Yeah, and then, so I'm inserting the wire without any resistance. I'm pulling the needle out, going to confirm that the wire is in the vein by looking at the ultrasound again. So I'm now doing a transverse longitudinal view. You can see the wire coming from the left upper corner through the skin directly into the vein. So we are in a good spot here. So now I'm going to use a 11 blade to incise the skin. Make a little nick. Then we're going to insert this micro dilator and sheath over the wire. This is going to dilate up the skin. You want to always make sure you have control of the wire. So I'm not letting go of it here until the end of the wire comes out here, so I have control of it. So now it's out here, so I have control of it. And this is a key step that a lot of people don't do. But when you advance anything over the wire, I like to wiggle the wire back and forth. Because if you move it all as one system, you can back wall the vein and go through the artery, cause massive hemorrhage. But if you slide it back and forth, you're going along the pathway of the wire. It's a really key step that I highly recommend people do. So now we're going to remove the wire and the sheath, or wire and the dilator, leaving the sheath in place. Always want to cover the opening. Always want to double check your work, so I'm going to make sure that there's blood coming out because we're still in the vein. It aspirates and flushes easily, so we're still in the vein. Now we're going to place the real wire, which is the 035J wire. This is a larger wire, so we're going to insert the wire into the sheath. The anesthesiologist is monitoring the heart, make sure there's no dysrhythmia. So I'm going to remove the sheath, leaving the wire in place. Still going to double check on the ultrasound. Again, that's a nice view of the wire within the vein. So now we're going to make the skin track a little bit bigger. So this is a real size dilator here. Insert it over the wire. Again, always make sure you have control of the wire. So here's the end of it. We're going to carefully dilate up the skin here while moving the wire back and forth. Same principles. 11 blade. Mosquito. Now we're going to remove the dilator. Don't want to pull the wire out, so I readjust it. So now we're going to place the dilator into the tearway sheath. Then we're going to insert that all the way. Same principles again, make sure you have control of the wire. We've had a surgeon at the local hospital here who let go of the wire. Wire got sucked up into the pulmonary artery. Patient did not do well. That's what you do. That's what happens when you have sloppy technique. So now we're gonna, without pinching the guy's face, we're gonna control the wire onto the drape over here. Now we're gonna switch sides over here. So now we're gonna make our subcutaneous pocket underneath the clavicle. Just like to do 2 finger breaths below the clavicle, approximately, for the port pocket. We don't like that, so the anesthesiologist is going to give some more sedation. But we're going to ultimately place this port underneath the pocket, so we have to make the pocket big enough to fit this in there, secure it in place. And then we're going to tunnel this catheter from the chest incision out through the neck incision, and then the tip of the catheter will be ending up at the top of the heart, at the SVC, right atrial junction. And then this port will be, or this catheter will be connected to the port, completely underneath the skin. So let me know when we're good. Another tip for the scrub techs who are watching, since we're placing a central line, make sure you always flush everything that we put in. So my tech has already flushed the port, so there's no air. She's already flushed the catheter, which is Less, we're good? Okay, all right. Okay. So now we're going to create our port pocket inferior to the incision. Make sure you don't have the assistant go like that, because then you can just back wall right through the skin. So you want to have it 45 degrees up, making sure you're not going to go right through the skin, because especially on skinny guys like him. So we're going to make a little pocket that's going to create, that's going to fit our port. So since he doesn't have much fatty tissue here, we're just going to go right down to the muscle. If you have too much fat, it makes it difficult for the infusion nurses to find the center of the port. Okay, come on. Let's switch sides. So I'm gonna cover the skin, because you want to minimize contact of a foreign body with the skin, even though it's already been prepped. You want to minimize risk for infection. So now we're going to place our sutures down to the fascia to anchor our port. This has a little, whatever you call it here, so you can put the stitch in. Now this patient has pancreatic cancer, so he presented with painless jaundice. He turned yellow without any abdominal pain. That's a classic sign for pancreatic cancer, which is not a good thing. And then he had pale clay colored stools, as well as dark urine. Come out. And he had unintentional weight loss as well. So he had a 50-pound weight loss over the past 6 months without trying. Forehead, stitch. And these stitches are to prevent the port from flipping. Sometimes surgeons are too lazy, they just stuff it in there without securing it with any stitches, so it could potentially flip if the port is too big or if the pocket's too big, and this is not accessible. There's metal right there, so it renders the port completely useless. So this anchors the port in place, so it prevents flipping. Switch sides again. So now we're going to tunnel the catheter from the chest incision out to the neck incision. Local. In order to help facilitate tunneling, if you inject local anesthetic, not only does it help with postoperative pain control, but it also helps with tunneling the catheter. So I just go underneath the skin, and I like to do a little curve. Like, you don't want to go straight there, because then the catheter will have like a too sharp of an angle, so if you do a little loop, it's gonna go in nicely. So inject the local anesthetic just underneath the skin, because you got your external jugular vein, you got other bunch of stuff that can be in this area. So you just want to go underneath the skin, make a nice little wheel. Just like that. Needle. And then I like to make this a little bit bigger here. I switch sides again. So I like to, this is my little spear. I like to put a little angle into it so it's going to curve like that. When I tunnel it, I like to have the pokey point towards the skin where I can watch it instead of going like that for obvious reasons. So we're going to go along the way that we injected with local anesthetic, with the tip up, with the spear up. So I'm watching the tip right there. Again, the tip is pointing up and it's going towards the target. My system is spreading out the corner so I can see the little opening here. So without pulling out the catheter, just gonna tease this, pull this through. Okay, switch again. So the way I tell it off the drape the patient, I know that the SVC rate atrial junction is gonna be right there at the nipple line, so I'm gonna put the catheter right there. At the end of the catheter, we're gonna trim this off. Whenever you insert a foreign body like some type of tube, you wanna make sure you put in more than you need to, because you can always put it in too far and then pull it out, but you can never finish the placement and then decide you want to push it back in, because that'll cause contamination. So you always want to give yourself some laxity. So even though the target is right there, I'm going to put it in a couple centimeters further. I'm going to put a little, see where it comes out in the skin. It's about 28 centimeters there. So again, you want to flush everything, so I'm going to flush out any air. We'll remove the dilator and the wire without splashing anyone. This is a one-way valve, so there's no blood coming out until we go through the valve right now. Then we insert the catheter. This snaps in half. So we're going to pull or split the catheter or the tearaway sheath away after I insert the catheter all the way. You want to pull the catheter or the sheath parallel to the floor. If you pull upwards, you're going to pull the catheter and the whole system out. And then I just hold it in place like that, and then we pull. And then I'm going back to the chest incision, I'm going to pull back to where I targeted before, which is at 28 centimeters. And come back here. Before we do our final part, I'm going to aspirate again. There's a good blood flow. It flushes easily, no resistance, so we're good. So now I'm going to trim off the rest of the catheter. This is our little adapter that's going to seal the catheter to the port. Hold this. Now we're gonna do the hardest part of the case, which is to put this tiny catheter onto the port hole. I like to use a little unfolded Raytech once I get the lip in here. And the Raytech kind of gives me some friction to push it in there. That's pretty good. So I'm going to squeeze the adapter on there. So now we're going to suture down the port. Up. Pull. Pull. So now our system is closed, so now I'm going to have the anesthesiologist place the patient in reverse Trendelenburg position. So now we don't want the vein engorged because we want to promote hemostasis, so we're going to elevate the head and the neck above the level of the heart. A little bit more. That's good. And then cut. These don't have to be perfect stitches because again, they're just preventing the port from flipping. Cut. So now we're going to check the port, make sure it works. So we're using a special Huber needle. We're going to access the port through the diaphragm with saline first. I'm going to aspirate it, get some good blood flow. The flush is easy with normal saline, so there's no resistance. Needle. So now we're going to lock with heparin, and then we'll sew up the incisions, and then we're done. And then we will get a upright chest X-ray in the recovery room to make sure that the catheter is in the correct spot. All right, thanks for joining us.